participating, and wanted to share with you some of the observations that are coming out of that, and some of the fascinating dialogue that having with the teams, and also what you can do in your organization to help support all of that. And then we're going to dive into a little bit more depth on the population health land coming up in the fall. I want to explain what the context of that is, what we're going to be working on, and then get to the measures and share with you the proposed measures and see if we can reach a consensus on those measures as we prepare to move in. So that is the overall game plan. So let's talk about change plan documentation. We pulled together some graphs that show you the activity over the quarters. These graphs, if you look in the far left, is the first quarter, which is Q4 from last year, when we started actually doing the reporting. And the far right, is the last quarter. And you are seeing a little bit of a progression of activity. This is relative to all of the items and all of the change packages. Now, when you get into an initiative like this, there is often a tendency to kind of check the boxes, that we've got to report this to the state, or we're going to do this, and you wonder if anything's really happening. And it is fascinating following your journey to see the level of activity that's going on in the field. Many of you are doing some great work internally with your own quality improvement efforts, and you're collaborating now at a very different level than you were before. The comments about motivational interviewing and having come into the area and supported several train-the-trainer models, and now to see that spread where that is growing across the community. Many of you were already doing some degree of motivational interview. It's not a new concept, but now you're really moving it to scale, which is fascinating. So you see over here, the far right is in each of the graphs is the items that are spread, and the far left is where there's just no data entry, or really in early stages or planning stages. So you'll see that from the first quarter, where there was just no data being entered with a couple of organizations, to the most current quarter, everybody's loading data. And you're starting to see in the fully implemented slide, starting to move up a little bit with certain areas. So a couple of organizations feel that they've already fully implemented some of the activities with their change package, which is great. Over time, we'll be able to continue to see the shifts. If we go to another level, this is really hard to see. But we'll share this with the group. But what this does is take each of the domains of the change package, and it allows you to start to see the shifts over time. So, for example, if you could see them, you could see them. So we'll share this with you. But if just looking at, for example, social determinants of health, you see that there was a lot of no planning for many organizations in the early phases, and now you're starting to see that moving up on the scale. Just as an example, so we're seeing activity across the board, different components. Where there is suddenly a group that is saying fully implemented, that should be a trigger that they must be doing something well. You feel that's fully implemented, perhaps there's some opportunities to learn from that. What are some of the best practices that might be evolving? So that's just really the utility of a tool like this, and over time, we'll be working with all of you to help decipher this. So one of the challenges in finding those best practices is how you document. And this is an example of the names not included to protect the innocent. But this is live data from a last report of one organization that put a data entry in, and it said we're planning on participating in the next pre-managed cohort. Now the system automatically allows you to pull over information you input from the last quarter. If you delete it, it doesn't roll over. So this is what it looked like included last quarter. This is a very different context. We began implementing the swim lane workflow that was a brainchild of our the land training. We are proud to identify the workflow, it should work, and they go on and give a fair amount of detail on what they're doing in their organization. So this breadcrumb trail becomes really helpful in seeing the progress over time. It's also really important if you have any turnover. If you have someone that comes into the organization that is going to be taking over, you're switching responsibilities, and then they have to say, what have we done in the past? It's very difficult to go back and recreate that and go through all the files. Whereas in the change plan land, if you capture the information, it becomes a running diary over time. So this is something we're going to be coaching the organizations on in the affinity group. And it's an opportunity for you in a leadership position to be talking to your whoever's doing your data entry to make sure that they understand the process. Here's another example of one that's fully rolled over. So you'll see here in the first one, it says our medical director has taken an active role in defining prescribing policy and workflows that are compliant with state regulation. One provider has obtained a Suboxone waiver. And you look in the next quarter, we now have 2 providers who are qualified to provide Suboxone. So from starting from ground zero to now we've gotten buy-in from our medical director and we got 1, now we've got 2, and so perhaps in the next quarter you might see 3 or 4. So over time you really see a story or something that is happening in the field that's truly being implemented that makes it very powerful. So any questions on this data entry? So the observation is that some teams are deleting the carryover of the data. The ask is not to do that, and to use it as a diary for your efforts, so you can go back and look at the progress over time and use
nice if I do that ahead of time.
Yeah,
I'm one of the deleters.
that's okay. This is all part of the learning, and again, this is a 5-year journey, and we're at the early stages, so this is all part of the process. We have time to catch up. Yeah.
We've actually downloaded the data, so we actually have it. So it hasn't been completely lost.
And thank you for your psychological safety of being able to admit that and bring that up, because that's one of the things we talk about. You felt safe to do that. That's great. Other questions or comments? Okay, that's pretty clear. So let's talk about psychological safety. So we have this team-based care LAN has been an effort to prepare organizations for some of the population health work. One of the observations in organizations that do population health work well is that their care team, who's responsible for a population of patients, really understands that role, understands how to use the data, and works across the care team to support the work in the field. That requires some change, requires change in roles, perhaps. Certain things that used to be on the backs of the provider might be delegated to other members of the care team. And all of that requires a degree of psychological safety. People have to feel safe, to ask questions, to be empowered to do all of this work. So we're shocked actually at the level of participation of the number of teams that are in this cohort. I think one call we had over 125 people, I think, on the call. It was just extraordinary. And through the calls, people have been open and sharing. And we've also been doing outside coaching individually with teams and with individuals who've requested coaching advice. So that is starting to open and surface lots of questions from the groups on, how can I further this in our organization? How can I move this forward? I've got another busy slide. Hopefully you can see this a little bit better, but let's talk about what's coming up out of the field. So we're hearing from some of the teams that this is really, really important stuff that they're working on, that they feel there hasn't been a level of psychological safety across the board in their team. Sometimes that's coming from a leader of a team who feels that the rest of the team isn't feeling safe. And sometimes that's coming from individuals who may be lower in the power gradient, if you will, who are vocalizing that in terms of the participation of the team. And then sometimes it's relative to the team and the rest of the organization. We don't feel there's psychological safety between our team and other teams in the organization, or psychological safety from above, where we're not quite sure what the ground rules are for being able to truly engage in a safe way. Now, why does that happen? And why is it important? Why this happens is a real frustration in leadership. As a leader, you feel like you're doing the right things, trying to bring people together and help lead an organization, and you constantly run up to this issue of staff feeling safe and willing to be engaged, willing to be empowered. I'll never forget, I had a administrative assistant worked for me for 12 years, and when we separated ways, she told me, she says, you know, I was scared to death every day I came in the office working for you. I said, are you kidding me? And I was so close to this woman, she was like part of my family. I knew her kids, her family. We had meals together, and I thought I was a very empowering, engaging leader, and it has haunted me to this day. You know, why does that happen? And what could I have done about it? And what I've come to realize after much research into this issue of what are the drivers that create this? Well, some of the drivers are our culture. We have a culture where leadership and management principles over many decades have focused on a frame of reference that people are often the source of our problems. They are the initial starting point. When something goes wrong, we point the finger, right? It's like it's their fault, right? I have a silly little example I'm going to give here. These three things in the hotel. Which one's a shampoo? Did you figure that?
Just bring it home and give it to the kids, so I don't even know.
So for those that are in the virtual world, I have three little bottles. One is body lotion, one is conditioner, and one is shampoo. And these are in the bathroom shower area of my hotel. So I saw this and I wanted to bring it up as a reminder. I had done some work with a hotel group years ago, and this similar type of thing. I went to the hotel manager and I said, you know, it's really frustrating. I just put lotion in my hair thinking it was shampoo. And his immediate reaction was, well, you know what? I'll get right on. You know, we've been telling those housekeepers that the shampoo is always on the left. Okay, well, how does that help me at 5 o'clock in the morning when I don't have my glasses on and I grab a bottle and go into the shower, right? Now that's a design flaw, right? That's setting the housekeepers up for failure. But our reaction is immediately to go, it would set me up for failure, and I succeeded in my failure. And it's happened more than once, which is also a failure of learning on my part. But we have this tendency that people are the problem. Now, secondly, a lot of the tools and systems that we've used in leadership have focused on trying to change people's behavior. People are the problems, so we need to change their behavior. Management by objectives. We're just going to put objectives out there and it'll drive people's performance. Use of fear. Use of extrinsic rewards. Pay for performance. All of that is outside extrinsic motivation trying to change individual behavior. So our starting point is that we drive fear into our culture. We also have an environment where fear is persistent because of hierarchy. The fact that you can fire someone, you can discipline them, you can dock their pay, immediately creates a power grading. And in a clinical setting, where you have a licensed practitioner who's on the hook for malpractice and for external regulatory review, that really ups the ante. Puts tremendous pressure on the practitioner to make sure that everything's in compliance, and that changes the power gradient as well. So all of a sudden we come along and say we want to have a psychologically safe environment after decades and decades of having environments that are often pretty hostile for staff. And we wonder why we have so much turnover in the environment. Now, what we're learning is there's a very strong evidence base that when you can drive the fear out of the organization and create a safer environment for psychological safety, it translates into patient safety. It also translates into lower cost, lower turnover, and higher quality. So Dr. Deming, his book was called, Driving Out Fear. Drive out fear out of the organization. His experience working in organizations observed that we treat people like lab rats. In fact, Dr. Deming worked for the famous Hawthorne Works plant, and I think it was in Missouri, where Elgin Mayo did the famous psychological studies of going in there and changing the attenuation of the lights, painting the walls different color, and every time they did an intervention, the productivity went up. And after a while, what they found is no matter what they did, the fact that management was intervening and checking created a stimulus. But that stimulus had a half-life. And after a very short period of time, people went right back to the behavior. It's known as the Hawthorne Effect. Many of you have often talked about or referenced. So Deming worked in that environment during the time that they were doing the Elgin Mayo experiments. They said, you're treating people like lab rats. What do you think? People drive to work every day wondering how bright the lights are going to be? What color is the wall going to be today? Oh, if it's pink, I'm really going to be productive. And if it's red, I'll be depressed. Now there has been some research that coloring can affect your mood and behavior. So that's not negated. But the point is that when you are just trying to intervene and change people's behavior and do that in a fear-driven way, it creates paralysis. Has anybody ever been in a situation where you were really fearful at work? Anybody care to share an example?
I was in AmeriCorps, and one of the staff had some kind of a mental health issue and decided that me and another person he wanted to chase around the office and threaten us. So we had to lock ourselves in an office. So I was legitimately afraid. Yeah.
A real life-threatening fear.
Yes.
And what happens when you have that life-threatening? How do you feel at that time? What does it do to you? What's emotionally, psychologically? What's your reaction? What was your reaction at the time?
I was tense, very tense, scared, and just thinking through how do I get out of this, and then also how do I continue on here? How do I kind of feel? I was worried about the future, so thinking.
Yeah, you're worried about the future. How am I going to be able to function and get over it? Yeah. Any others? Yes.
A long time ago, before I was raising my son, I worked for judges, and one of the judges was extremely inappropriate, and my only recourse was to go to a fellow judge of theirs to make a complaint. It was probably one of the hardest things I've ever had to do because, a judge is the pinnacle, in an office of the law. When they actually break it, and then you're, down here, it's really frightening.
Yeah, talk about the power gradient difference. I mean, with the judge who's the top of the chain.
Top of the food chain.
Right, and in an environment where peers protect each other. It's easier to go away and disappear as a problem rather than address it. So that was incredible courage on your part. What did you experience as a result of that? How did that translate into your work productivity in your daily life?
Well, I was always extremely careful, with that particular justice, and an apology was issued. It just seemed like the tension from there on out was so high because I had done, I should have just put up with it and not said anything. And the other judge was extremely supportive, but it still makes tension in the office,
Right.
Doesn't seem to ever go away. So you're just very, very careful.
So that tension is just persistent. So you're just walking on eggshells the whole time, and you become paralyzed, and you don't want to take any risks. You don't want to step out of your role, otherwise.
And you doubt yourself. You doubt that, did I make the right decision, not just for myself, but for other people. And so, I'm not confrontational in any manner, and to actually to go in and say, this is really, really wrong.
Yeah.
Is a big deal. And for me, for a life-changing thing. But it was, the tension didn't go away until I actually left the position. So.
Okay. Any other examples? It's not meant to be depression clinic, by the way. So yes, go ahead.
Mine is not nearly as dramatic as the last two examples, but as a single mom, I was the only one. I had no support for my son, and so it was truly a matter of feeding my kid. That you have to do whatever it takes. And the physician that I was working for didn't have any children, so he was a great boss. He paid me well. It was a great environment for me to get what I needed accomplished. But because our lifestyles weren't aligned really, there was always a problem with, can I get off in time to pick up the kid from daycare? So, and I ended up having to quit the job because it really became an issue of, I can't work every night with a 5-year-old. I can't work every weekend with a 5-year-old. And he truly didn't get it. It wasn't that he wasn't unkind about it, but he was so focused that discrepancy there in our lifestyles just made it so that, and it was the hardest decision I think I've ever made, because in every other way it was a great working environment, but to have to make those kind of decisions just because it doesn't fit with the lifestyle can be a big deal.
It's a great example of how it can lead to turnover. And there wasn't a safe environment for you to reconcile that and align and have a more meaningful discussion and help build his awareness and figuring out a mutually beneficial pathway. And that cost him in terms of productivity and turnover and retraining and all the things that go along with that. So, the other thing is we're all time compressed in leadership and in our daily work with just too many competing priorities and never enough time, it seems. And so it's easier to kind of bark an order or give a command, just say do it, and not really work on the psychological safety pieces. So the evidence base, as I said, is pretty strong. There's lots of resources coming from the high reliability environment right now. For those of you in hospital systems, Joint Commission is really pushing high reliability principles. All of that is centered around just culture, creating a safe way for members of the care team to be able to step up and voice a concern to address the safety issues. I have a little bit of a challenge with that. I think the high reliability is kind of being taken over by the safety movement when those principles apply to almost everything in the organization. And we need to make those much broader than just the safety arena. Kouzes and Posner wrote a book on trust. This is a textbook that's used. I've used it at Hopkins. It's used at Harvard, elsewhere, that really focuses on one of the major drivers in daily productivity is trust between leadership and the workforce. And as a leader, we really need to understand that trust component and build it in. So strong evidence base behind it. Okay, so what? So what do you do about it? So this all comes down to really purposeful design of systems. I talked about the lotion as an example. It starts with really thinking through what are the systems that are supporting our care teams, and this is a role of leadership. How are we making sure they're perfectly designed? I remember in the early days of the ATM cards, talking to a bank, and the bank was complaining about all these idiots leaving their bank card in the machine. I mean, it's just crazy, who would leave their bank card? Well, I'm with you on that one, right? I mean, that was a common thing, and they blamed all of their customers. Was a purposeful step. They blamed their customers for this problem until they studied the business case. How many cards were they replacing on an annual basis? How much was going into fraud detection and tracking down? And it was a huge carrying cost because of system design. Now, you can't find an ATM in the country that doesn't ask you to take your card out before it issues and it beeps, right? So that's called a forcing function. They build a forcing function to get your card, right? So that comes from purposeful design. So you can yell at your tellers, you can yell at the patients or customers, you can do whatever, but that's purposeful design. Empowerment is a system. So it starts with smart design, really empower your employees to be able to do their job well. Secondly, there's a policy component, and this is where leadership comes in. What's your policy for really empowering people? What are the boundaries that a care team should be able to work within? What's within their scope of control? Now, there's a famous story of FedEx when they really pushed empowerment and of an organ that arrived at a FedEx facility in New York, that had to get, I think it was to Boston, and they were closing. And they explained that this was for an organ transplant that had to get there right away, just missed the flight. So this guy took a FedEx truck and drove to Boston and delivered it to a hospital, right? And they brought him in, they almost fired him. It was against all the policies. You took this thing after work, you weren't on, it was on your shift, you know, there's liability, our insurance doesn't cover you out of state, and I mean, the list goes on and on and on. But what was the right thing to do? Right? He did the right thing to do, and that's when they realized, you know, we've got to change our policies. We've got to create an environment where people understand what the rules of the game are to be able to support that kind of work. Third, there needs to be training. With whatever systems you put in place, you have to train people. So the Ritz-Carlton Hotel, which I often reference, you know, they had a policy that staff had up to $1,500 signature authority to fix something they see broken. Right? So every housekeeper, if they see something, they can order it to get fixed. And if your internal group can't fix it, they can get somebody from the outside to fix it. I remember dealing with a colleague who ran a Ritz-Carlton Hotel. I said, Paul, how I did that in my organization, I'd go broke. I mean, how often does that happen? And he goes, maybe once a year. What? Once a year? He goes, oh yeah, you think we just let people have a blank checking account? He says, you know, we really train the heck out of people on how the processes are, how to get something fixed, and we train our staff to get things fixed. And everybody's empowered to do that. And so people use good judgment, and when they don't, we do a very in-depth analysis, and we really celebrate the wins, and we make sure those failures are really prevented from happening again. We build that in, right? It means tools. What kind of visual control tools can we share with our care teams, with our organizations? So Marriott, Marriott has a thing they train people, I probably referenced it before, in terms of their service excellence. And it says at 15 feet, look the customer in the eyes and give a warm smile. That's in the hallways, behind the scenes. As you walk through their back hallways, every employee sees that regularly. The visual cue. And it's remarkable how many of the staff actually greet you now. And that's throughout the Marriott system. I'm staying on a Marriott property here. And the staff immediately, as I was walking in, were looking at me, waiting for me to come in. Right? So that's a visual tool. Now, if we just say, look everybody in the eyes, and that's the extent of our training, very high failure rate. People can't remember, all of those kind of things. So you have to build that in as part of the system. You have to monitor it. Marriott has secret shoppers. They go in and check in the hotel, and they make sure that everything that is in their standards or policies are being adhered to. They monitor it. They follow it. They make sure it's happening. So really building that in. They reinforce. They follow up. And again, they celebrate their successes, and leaders do the role modeling. So that's a system. It's designing a system. So in the team-based care land, we are working on sharing tools with the teams, helping to talk about how they work as a team, how the dynamics, what can they do to optimize their work. And most recently, we started sharing some of the tools to facilitate open and safe environments. So one of the tools is a STAR, asking people to stop, think, act, review. Many of you are familiar with this from some training you've probably done in with safety or other arenas, the team steps from the AMA and other groups. A very common tool, but not commonly practiced. Right? You have to teach the teams and give them the opportunity to practice it. Another one, the ARC model. Ask a question, make a request, voice a concern, and then if you have to, use the chain of command. This is when there's something really, really serious. You're finding something at work and you're not able to get through your supervisor and having to go one step up if you feel it's really life-threatening, and making that safe where the supervisor doesn't really create retribution. And that's one of the most difficult things I find in leadership, is when the mid-level manager is part of the problem, is the one that is using fear, is blocking, is using retribution. And that's something that in leadership we all have to work on. And in our role, if we are in middle management, how are we contributing those negative forces, and what can we do to build that safety? Any observation, are you hearing anything from the teams relative to any of these tools?
I just wanted to say, Christy from Catholic Charities put in the chat box, we have to shift the culture where staff are the decision makers, where they feel safe to fail. Daniel Coyle talks about this in his book, The Culture Code, and I think this is a huge shift. And you talked about the Marriott 15-foot rule, which is what Rebecca also referenced in her chat box as well.
Any observations for those of you that are using these tools, or your teams have come back and said, you know, can we use these tools, or how are we using these tools, or anything you're observing? Is that someone on the phone about to speak, or just rustling papers? Rustling papers, I take it. What are you observing, and what are you doing to create safe environments for your teams to be able to work together, change roles, collaborate in this new world? This is the participation part of the agenda. Yes, yeah.
One of the things that we did was we have a team for each section of our change plan, and the leader of the team was chosen, was pretty open. People got to volunteer, so you could be anyone in our organization if you chose to be the leader of that team. And then the leader got to choose who the team members were. They got to reach out and say, I think this person would be a good person on my team. So I think that helped spread the change plan information out to a lot more people that way, but it also made that they know that they're the leader and they get to do the things a leader would do on a team.
So really clarifying the role of the leader,
right,
and what the rules of the game are, what the boundaries are, and what the opportunities are, making that transparent to others so that people can understand who to go to and how it works. Okay, great example. Now that role clarity is fundamental, and all too often staff say, I'm not quite sure what my role is. What am I supposed to be doing here? What am I allowed to do here? Other thoughts? Any other observations? Yep.
On the topic of, the monitoring, it could almost be where the staff would be frightened that some secret shoppers catching them do something wrong, when it could be that the secret shopper found it attaboy and that it actually was a great thing they did. Would they elevate that? Or?
Yeah. So yeah, that's a great observation. So depending upon how you execute on that, if the information is used to punish people, then it just becomes negative. If it's used to observe compliance and where there are breakdowns and what we need to do to train or use it to improve, then it can become a positive. So being very clear. Executive rounds. I don't know how many of you are involved in rounding in organization. Rounding can be extraordinarily positive or extraordinarily toxic. So if you round and all you're doing is pointing out the negative, then you are not creating a safe culture. If you're rounding to listen and look for system flaws, things that can be fixed that are not navigating its way through the bureaucracy, and you can really help the organization profoundly. And it is amazing how often we don't understand some of those fundamentals because we haven't trained on it. And we're not clear on what our roles are in that process. And and we don't have standardized scripts to work on, to really execute on that. I worked last week with a leadership team of a very large academic medical center that put in rounding recently, and it was a disaster. And the leaders are all shaken because of the negative feedback they got. And they made some changes through some coaching, and they stopped the finger pointing and started looking kind of inward. What's that saying, that when you point, there's 4 other fingers pointing towards you, right? So they're really understanding those roles and clarifying them and building in the systems to support it. What else? What other observations? What other interventions? Anything else that's working and building a safe culture in your environments? What are you saying? Yep.
We went through the 12 attributes of great leadership, And one of the sticking points is that for us, we kind of got stuck on, okay, now we get what these great attributes are. We're starting to gel as a leadership team, being able to share with each other and sort of use brutal honesty, if you will, with some leaders look to the people. It's not their fault, it's their fault, not coming back up to I'm responsible for this, or the system is responsible for this, or what can we do? But you know, we're mixing everyone from facilities manager to clinical director to office manager. There's a lot of different communication styles, and some people are very open to feedback and talking, and others are, this is very foreign to them and feels highly hostile and uncomfortable. And so just trying to figure out how to gel, and we're starting to, but this is a great way to next steps, because it's like, okay, what do we do with this now that we're starting to gel? Now how do we take it to the next level?
And when you throw on the other cultural domain, when having people from different cultures coming in who are not used to the openness, it may be from a very controlled environment where it's not polite to challenge or it's not appropriate, you know, creating a safe environment for them.
Not brutal. Just call it radical candidness.
Radical candidness. And how do we solicit feedback? In teaching, one of the things I do now is I take Post-it notes, and at the end of every class, I hand out the Post-it note and ask students to write 2 things they learned that night, 1 suggestion on improving that lecture for next time, and put it on the Post-it on the door as you walk out anonymously. I am blown away by the honesty and the profound insights that the students will give us feedback that they would never articulate if I gave a survey or if I asked people to comment. And extraordinarily helpful to be able to do that. So think about that. If you're rounding, I'm going to hand out a Post-it note, anything you want to bring up that you don't feel comfortable, you know, throw it on the door on your way out. Collect those, and you'll be surprised at the power of some of the information you get back from the staff. So there are a variety of tools. These are just 2 of the tools we've been sharing, so you may hear that from the teams. So what can you do as senior leaders and leaders helping to support all this work in your organization? So one of the things that we are coaching the teams on is whoever the senior people are on the team, figure out who the person is the lowest on the power gradient, the person with the least authority or power or influence on the team, and go have a conversation with them about their observation about psychological safety. How safe is it to be here to bring up things? And to do that in an honest, meaningful way, have it in a spirit of learning. And try not to get defensive, but to listen. And encourage all of you in a leadership position, if you have teams that have been participating, you're not part of that team, then go out and engage the team. Do the same thing. Do it with the leader of the team, but also with the person who you think might be on the lowest rung. And do it in the spirit of open learning. And what you're looking for are kind of system themes, not necessarily individual, you know, gotcha themes. And see what you learn from that. And that process of doing that is a very strong message to the teams. Be thinking about how do you scale the work from one team to others in the organization. And we have an organization here that has multiple teams, and they're using this as part of a spread opportunity. So a lot of the teams are hearing the same message. But most organizations just have one team, and they're moving along and starting to use these tools and starting to evolve. The question is, how do you move that learning out to other teams in the organization? Can you create a train the trainer model, or what's the opportunity to turn this into a real case study that others can learn from in your organization, where you're really getting the power or the investment of time and resource of the people on the team?
Roger.
Yes?
In the chat box, Rebecca said, we had our teams look for opportunities to recognize each other, leadership included, and share one another's strengths, which created a culture of safety to speak up about opportunities as well.
So great insight. So the ability to hear from the team. It's like the Post-it note. Hear from them and then share that across a broader environment creates that safe environment. So that's a good example of role modeling the behavior. What can you do to help role model the behavior? One of the great lessons and insights in my leadership career was to stop directing and ask questions. So I used to go do this. And instead it's, well, how might this work? Or how could you do that? How could you move that forward? And so asking questions is a technique of role modeling the behavior, insightful questions. Other mechanisms to engage. Anybody doing anything else to engage the care teams in this process?
So at Family Health Centers, we have multiple teams. And one of the things that's been kind of fun to watch is the teams are participating in the LAN, but then when they're doing their homework, there's several of the teams that go back and do the homework together with the whole group, as opposed to just the people that are participating with the LAN. And it's kind of interesting to see the clinic sites that are doing probably the best, probably don't have the best homework report because it's all dialogue. It's not captured. The beauty of it that's happening isn't necessarily on a piece of paper that they submit on their homework. The ones that are more controlling about the homework and making a perfect homework assignment are doing it with a few people because you can't really have that conversation with that kind of detail. So it's been interesting to watch that roll out. And I think now that some of the teams are kind of getting the hang that this is more about actual change as opposed to an assignment, that's kind of going through the organization, that this isn't about the homework. This is good stuff, and that the staff is really excited about it. The providers are pleased that we're doing this. It's been a really great experience.
What are you observing in terms of the change in dynamic in the organization?
I think our biggest change has been more valuable huddles. The huddles were kind of a we have to be there for 5 minutes of whatever, and now that they're using some of these tools to actually make it meaningful about how that day is going to go better, that more people are showing up, they're engaged, they feel comfortable contributing to what they're going to talk about during that time, as opposed to just a manager or a lead being in charge of the huddle and giving them information. It's actually a conversation now. And in one of our clinics, just by changing it from a mandatory thing that they get in trouble if they don't go to, they took that out, but let the actual staff, the manager and the lead nurse are no longer necessarily involved with it. It's now their huddle. So it has changed that dynamic in a pretty significant way. So it's theirs now, as opposed to I'm required to be here for this 10 minutes of when I'd rather be drinking my cup of coffee.
Any questions for him? Any other sharing in terms of what you can do to build a safe culture around the teams? Anything in the virtual world? To remind me today is, before we leave, I'm going to hand out Post-it notes and ask you to reflect on 2 points today and anything you'd recommend for next time.
I was just going to say, I took your idea from one of the previous meetings to evaluate the meeting. What went well, from 1 to 10, evaluate the meeting, and then what did you like, what went well, and what would you like to see that would make it increase from that number to a better number. And some of the feedback was people that were that talked in the meetings would say, this would be better if I'd heard more from so and so and so and so. I felt like I didn't get enough from them, which then created the space of, we want to hear from you. And they were people who look at themselves as, I'm the cook. What would I have to do about the clinical piece of it? It's like you're involved with the patients on 3 times a day. You have a lot to do, with the patients. And so it gave them sort of the go-ahead, and really are part of the team, and we really do want to hear from you. So that was interesting to watch them feel empowered.
Wow. Yeah. That's funny. I worked with a hospital, and they put all the housekeeping staff through a human factors design workshop. and really understanding customers and their needs, and told all the housekeepers that you are now listening posts for the nurses. So when the patients start volunteering things to you, now before you never said anything, you don't want to say anything, bring those to the nurses, let the nurses know, let the staff know, and had a profound impact on the organization, because the patients often felt more comfortable and saw the housekeepers who were coming in there and engaging them and share things that they would never share, again, because of the power gradient issues with other members of the care team. So really seeking that out and finding ways to connect them, and very, very important. All right, anything else on the psychological safety? Any questions before we wrap this part up? Any comments or questions? All right, let's talk about population health then, the last thing for today. So we're going to be moving into a LAN activity in the fall, and beginning in October. And there'll be a little bit of pre-work that we'll get out in September. We're hoping all organizations will engage and actively participate. This is designed. Yep.
Sorry, one last thing on the
Sure.
on the first stage. Rebecca said one of the most empowering things a leader can say to their team is, do not hesitate to tell me if you think I am off or on something you have a different idea for an approach. I want to hear your thoughts. So a leader saying that to their staff.
So leader really empowering their staff by being that role model and communicating that key message. So the population health LAN is designed to really fulfill the spirit of why you're all here, is whole person care. The historical model of our healthcare system is up on the left-hand side, which has been predominantly episodically focused and built around provider. In fact, the staff that are involved, we call support staff, who are support of the provider. This is a slide from South Central Foundation, Doug Eby up in Alaska, for a nice Aldridge winter. And shift in population health is to now step back and focus around the patient and the population, and really understand the whole person needs of that patient, and begin to reorganize the care delivery around patient. Now, there was a study not too long ago that looked at when a patient comes into a clinic, whether it's behavioral health or primary care, what would need to be done to them to meet all of their healthcare needs. And it was like 18 hours of work that is needed for what is typically a 15-minute office visit. Behavioral health, it's a longer office visit, but still not enough time. And in primary care, we haven't historically been really addressing the behavioral health issues. And in behavioral health, we haven't been addressing the medical issues. And so our people are walking around with tons of issues that aren't getting addressed. And when you step back and say, if you could do it all over again, how would you redesign the system? You start to see that there are opportunities to change the way we engage, we organize, we communicate, the tools, the resources to get care done. Now, if I asked any primary care provider, and if I asked many behavioral health providers, what are the latest guidelines for diabetes care? And how are your patients doing? Almost 100% of primary care providers can almost spout off the guidelines verbatim. And if I say, how are your patients doing? Well, all of mine are off the chart. We're doing great. Let me tell you about Mrs. Jones, who had a hemoglobin A1C of 14, and it's now down to 6. And then Mr. Simon, who came in the other day, and he was really a train wreck. He was just on the verge of collapsing, and now we have him under control. So my patients are really doing well. And when you actually look at the data suggests that that's not the case. That, across the country, historically, the famous Beth McGlynn RAND report said that people, about 54% of the time are getting care according to the guidelines, the evidence base, and the rest of the time people are falling through the cracks. It's improving a little bit, but still not to the point where we need. So many areas, colorectal screening rates are very, very low. and they could be very, very high. And for the challenges, if you're in a busy care practice and you're seeing patients, you have evidence of people you've taken care of that are doing much better. But, where are all these people falling through the cracks? Well, some of it is through our systems, and some of it are all those people in that middle at risk who aren't coming in for the care. So you'll often find that there are people on the panel who the practice may not even know they're on the panel. They've been assigned, recently by a payer, or been in the practice and haven't been seen the last couple of years. Could be a young adult who's pretty healthy, but may actually be getting diabetes, schizophrenia, depression, all sorts of things going on with them, and they haven't been coming in, but they're still part of the panel. So population health starts to move us into who are the people we're responsible for, and how do we know, and what do we do about it? How do we organize and reorganize the care around that? So this is a kind of a busy slide again. It's in your slide deck, but that left-hand side are all the different payment models now that are pushing patients and practices towards value-based reimbursement, the latest buzzword, how we're going to get paid differently based on a population, outcomes, and different kind of work. And that means we have to know who we're taking care of, that they are truly our patients, that our patients know we are supposed to be taking care of them, that we are working on optimizing their health status, and that we are really working to protect them from harm through safety and other kinds of activities. That means that there's got to be a strong foundation of systems in there to make it all work. So the work of the population health plan is going to have two tracks. It is one that is focused on primary care predominantly, and the second is going to be for the behavioral health organizations. We have, there are design issues around the behavioral health cohort because of the nature of the behavioral health organizations that are participating. They're very different practice settings and different types of how you would assess the population. And we want to make sure we really get that right. We've been reaching out and having conversations with individual organizations and folks. And we'd like to schedule a call for those that are just focused on behavioral health panels of patients to talk about some of the design considerations here. So we'll reach out to you through a poll and see about doing that in the next few weeks, so we can make sure that we refine it and get it right. The primary care side, we are going to be working on the best evidence-based practices, starting with the state's master change plan and what are some of the population health resources in there, and then drawing upon nationally benchmark resources to bring the evidence base to help organizations best understand how to apply that. Some of you are way down the pike and have very mature population health programs. Others are just at the beginning, and that's all okay. We hope for those that you have very mature programs, you can use this as an opportunity to help refine and bring new opportunities to your systems, and that'll be an opportunity for you to hopefully share and also bring the whole cohort along. For those of you who are just at the beginning, that's okay. So you notice where it says here, know your population. That's one of the reasons we focused on empanelment as some of the pre-work going into this, this population health plan. For those that weren't far along with empanelment, really understanding who your patients are is really critical. So it is also recognized that there's some groups that aren't fully empaneled yet, and that's okay. So you'll move that along with the population health plan. In this, there's a whole series of best practices and tools and things that you will be working with. So for example, in the care delivery area, there's a whole opportunity in care delivery redesign. Alternative visit types as an example. In working with our colleagues in Oregon, and some of the practices, they've identified up to 25 different alternative visit types of how to engage the patient and do that in a way that can optimize the resources of the organization. So we'll be going in, that's an example of some of the things that you're exploring. How are you able to better engage and support and communicate and all of that? How are you risk stratifying the population? to target your energies where the most appropriate and be able to intervene and help move the numbers along. So we'll be covering many, many areas here. It is not a canned program, a canned initiative. It is going to be very much evolved around the needs of all of you coming in. So we'll be working with you regularly, and we'll be using this group to come back to and say, here's the next body of work. Are we getting it right in terms of the content and the pacing and the adjustments that are needed along the way? So let me stop there and see about questions about the land before we get into the proposed measures. Any questions? Would behavioral health organizations be willing to get on a call and talk through the design? Yeah, see some nodding. Okay, great. Super. Any questions from the primary care group? At this point, okay. We'll be coming back to you with a pre-work guide that goes into a lot of depth on selecting a team. It's intended to be able to be handed out to the actual team members. So it goes into a lot of depth, clarifying the roles, what the expectations are, how it's going to work, all of that, so that we'll get that out to you as soon as it's feasible. So here are the proposed set of measures based on having conversations with some of you in our previous meetings, going through all the change plans and seeing what people are already collecting, looking at what some of the payers are asking in terms of data, what HRSA has been asking, and trying to hit that sweet spot of minimizing the burden on you, maximizing the value. And where possible, please use this as an alignment opportunity. So if you have I'll use David's organization in the back there. If you have a team that's working on diabetes care and they're already performing and you're doing that for HRSA or some other project, they'd be a great candidate to be in this cohort. It would help augment their work and help meet their objectives without creating another team that's seen as another project in the organization. So where possible, create alignment opportunities where that makes sense for your organization. So the proposed measures, the first one is, is the comprehensive diabetes. This is the hemoglobin A1C and poor control. The NQF citation is there, and there's a national kind of a benchmark of, I think it's 40.5%. There's two measures proposed for diabetes, and for those that are challenged, there's some alternative measures proposed. So the first one I mentioned is hemoglobin A1C and poor control, and the other one is the hemoglobin A1C testing. In looking at the data, there are still many organizations that may not be routinely testing for diabetes, and given the prevalence in the population, this is a high opportunity. So that's a benchmark. By testing and identifying, we have an opportunity to move the needle pretty dramatically. So it's a pretty low-lying fruit indicator that has high value and pretty routinely easy to do. So those are two of the core measures. And then the alternatives are percent of Medicaid beneficiaries in a designated population segment who received a screening for diabetes mellitus within the last 12 months. So this means, let's say that you are maybe in your environment in a behavioral health context. All of your population might not be candidates to work on diabetes, but you might have a cohort that are, let's say, the institutionalized patients that you're caring for, and you're sending providers in to work with those patients. That's a prime target population. So it's a segment within your broader population. And as we get closer and into the meat of the launch of this, we'll be doing pre-work calls and going into how to collect this data and what it really means and how to use it. But that first one is just finding a segment that makes sense and it'd be appropriate for you as value added and where you're going to be able to have a high impact. And then let's look at that's going to be our group, our population of focus. Then the other one is the percent of Medicaid beneficiaries in the designated population segment who received a screening for diabetes in the last 12 months who followed up with a PCP. This is you got them screened, and then that percent following up with the PCP. You're making that connection of the screening, or you worked with the PCP to get them screened. So that loop is being closed with the screening. Okay. All too often, We go through the process and then the loop's not closed and the person ends up in serious shape. So those are the proposed diabetes measures. The depression measures are follow-up, the percentage are screened for clinical depression using a standardized tool. And then I think this is merged, should be 2 dots here. And then the one is follow-up on a positive screen, the percentage of members who screened positive for depression and received follow-up care within 30 days. That's also UDS measures.
Reported in our report, quarterly reports, it makes it look like we're not really doing our job because we screen everybody that comes in for an assessment, and out of that, only so many would meet the criteria for a referral to mental health.
Mm-hmm.
But it's going on how many we screen and then how many were referred. It makes it look like we only do our job like 4% of the time.
Right.
And that's not a really fair representation of what we're doing and the work we are doing. In the numbers, that's what it comes out.
Yeah, and all, you know, I think all data are wrong. Most data are useful, as the old saying goes. So the question is, as we get into this, you know, how can we annotate the data? So that would be a great example of potential annotation. That out of the data, you know, only 4%, but out of that, that was 90% of those that would be eligible or appropriate, and we're referred. So, you know, that it meets, that's appropriate. It's not necessarily a negative comment, but for the uninformed, looking at the data, they might draw the wrong judgment. So that's where we'd want to annotate data as part of the reporting. And that's all part of the learning in this process, is how to best can we communicate it, how are we going to analyze it, how are we going to move it forward. The other opportunities, the utilization of PHQ-9 to monitor depression symptoms for adolescents and adults, all members 12 and over, during who had an encounter during a 4-month period with a diagnosis of major depressive disorder or dysthymia. Numerator documented results that was administered at least once during the 4-month period. So all of these measures in theory are standardized. Most of you are collecting them in some way. They align with state measures as far as we know. Most of them are connected to the HEDIS measures that people the payers are looking at and others are looking at, and should minimize the burden on you, but be clinically relevant, and where we have an opportunity to move the needle. And as a group, we're going to be able to show, if we can get everybody focused on this, that we're really having an impact on the population of people with depression and diabetes. Now, it's very important to state that everything we're going to be talking about in this land is applied to all chronic diseases. We are choosing 2 to focus on, because we can't boil the ocean. We don't want to spread you so thin that, oh, we're going to do asthma, we're doing this, and then HIV, and you know, it's like, oh my gosh. So we're going to use these as the laboratories to really help teach population health, show the teams how they can move the needles, and do that in hopefully dramatic ways. And then hopefully all of you, through that, will be able to look at how this can spread to other populations. And what this tees up in the future, as we get good at this methodology and burn in the system, that this group can start to identify conditions in the region that you want to do focused work together on. And next one might be asthma, the next one might be cardiovascular, or whatever it is. And you can start to say, okay, let's get a group together and let's see what we can do now. Sharing best practices, what's working, draw in the best from the outside world, and really move the needle. Or you could identify indicators that you're behind on here for the state, and we need to really apply this to some of those indicators so we make sure we're not leaving money on the table. Wendy, it looks like we have a comment.
John from Parkview Pediatrics says the diabetes measures are aimed at adults and they do not fit the peds population. We make sure that we are able to address that so they have a place in this land.
So diabetes not in control would not fit a pediatric population? Am I missing?
Well, I will say Kathy responded that you could consider screening high-risk older children and adolescents, those with 30% percentile BMI that is high or strong at the age of DM.
Yeah, that would be your percent of blah, blah.
Right, the right segment.
Right. making sure that we're taking into account the
Absolutely.
Say adults only anyway.
I think the original intent was not to differentiate as adult. It was intended to apply to the whole population, but if we didn't get it right. Kathy, if you're on, any comments from you for the group in terms of the measures?
I just wanted to just reiterate that you would only have the 5 measures. There's one there with a patient experience. So each team would only have 5 measures. And I totally agree that the patient segment you choose is going to be really important, especially for those of you who already have an existing program you don't want to duplicate. But those folks may want to add an additional segment. So Dawn, I think your point's well taken that all of the pediatric population, if you look in total, the number of type 1 diabetics you have in young children is likely small, but we do know that there's an increasing risk for adolescents and older children. We're seeing more and more, so maybe it's a screening program there. But I think if you can find within your population a group of patients for whom one or the other set of diabetes measures may pertain, and perhaps one of the depression measures would pertain, it doesn't have to be the same segment. We'll work on you. Mostly what we want to do is demonstrate the public health tools as Roger described them, so that you're managing a population of patients. We're only going to look at these measures, as Roger mentioned, although these tools are appropriate for all chronic diseases, and they're actually appropriate for prevention. So once we learn how to understand segments of our population and manage those segments well, it helps our entire practice, the health of our entire practice.
So the last thing I'll put on the table, I'll open it up for dialogue, is I'd like to engage our payers who are in the room to see if we can support the individual practices and by sending them the data that would align with how you measure these indicators from your claims data. And do that once we've identified who the participating teams are, and we are able to give you the names of the participating providers and their care teams. We would ask that you be able to send that directly to them as part of this on a regular basis, so that they're empowered with the data, that they're at least the outside world is seeing them in terms of the claims experience. And they'll be looking at their internal EMR data, in theory feedback, but not often there are some data integrity issues, so this should help you with improving your data integrity as well as we learn through those systems. And this, I think, will be very empowering for the provider and care teams. Any reactions to that from our payers who are participating? And I don't know who you are, so except for one of them, I think. Who?
This is Courtney Ward with AmeriGroup. I'm comfortable with that request. I think we need to streamline how each of our systems can pull this data so we can do it, seamlessly across the payer systems. But we can definitely take the ask back.
Great.
Same for coordinated care.
Super.
Jorge, you're on the line. Can you respond? Just get your feedback. If you're still there.
We continue to work on how we share data, but these are fine for us.
Great.
For the 3 payers, would it be helpful to set up a call with us and maybe Roger and Kathy to look at the metrics and how we can all agree on how to streamline that? Because they're all HEDIS measures, I believe, that we've asked, but how we break it down by demographics. And that you would be sharing to the organizations, not to the ACH. So you'd share organizational data to them. Would that be helpful to you guys?
It should. Wendy, and we, Molina, are already producing a monthly report that I believe includes most of this except depression. So I think if we just huddle at some point, we could agree to how we do it going forward, I mean.
We can set up a follow-up call and talk through what we can do to help support you in those workflows. I think it'll be a win-win opportunity all the way around for the organizations. So let me open it up. What's the reaction to the proposed measures? They seem reasonable. No one's fainted that I could see in the room. Perhaps on the phone, but not in the room. Any concerns about the measures? You heard about the pediatrics. So part of this is making sure we get the right segment or subpopulation that we're focusing on. Okay.
So we currently screen, check for screening for diabetes for patients on atypical antipsychotics. Would that be an appropriate population segment, or would it have to be by age group? Like a certain class of medications.
Yeah, one of the issues I think is going to be size of the population. So if the numbers are you have 11 of those patients, that's probably too small a sample size. You got a lot, it's probably not going to be an issue. Then the question is the incidence that you're seeing in that population sensitive enough that you could see a change over time. So if you know already that you're screening them, but only 1% are triggering for diabetes, and so that's 4 people a year, you're not going to really see much of a change because it's such a small sample size. So it really would come down to how many of that population. Now, if it's like the rest of the population, and you're seeing anywhere from 12 to 25% incidence of disease, then it may be much higher, and that would be certainly appropriate. So you're seeing it's much higher for the population. Yeah.
One of the side effects of the medications.
Okay.
I could also add for Craig and for CVCH, because you have both behavioral health and primary care, you could look at it from both perspectives and have 2 different teams. Thinking of your diabetes metrics that you're following, if you have a team that you want to help boost their metrics in a primary care setting versus the behavioral health also participating, it may be a good opportunity to get them involved as well. And the same with CVCH if they're interested in sending 2 teams and looking at it from 2 different perspectives because they're 2 different populations. And Stephanie Dallas said, they're easily aligned with current plans we have. And Kathy said, and we are here to help you figure out the segment. It might be a group of those on secondary antipsychotics and those with BMI greater than 25, helping keep the numbers manageable.
Any other comments or questions on the proposed measures? Sound reasonable? They're meeting a sniff test? Seeing positive nods? Okay, super. Any other questions for today? I'm going to circulate Post-it notes. Okay? So this is role modeling the behavior. So as they go around the room, 2 things you learned from the didactic piece and the dialogue. Any suggestion for next time, or any concerns, or anything else you want to put on there? And you can put that on the door on the way out, but I'll turn it back over to Wendy then.